Hello, I'm here to talk about the therapeutic engagement and observation policy and focusing just on must-knows and frequently asked questions. Why do we have the policy? Observation is an integral part of the inpatient care plan that contributes to keeping our patients safe and managing risk. What is the definition of observations? Observation is a minimally restrictive intervention of varying intensity in which a member of the healthcare team observes and maintains contact with a service user to ensure the service user's safety and the safety of others. Let's focus on the patient experience and the therapeutic elements of this policy. When we consider observation, we must always be thinking about the two-way relationship. So that's the relationship that exists between the patient and the staff team. Observation also provides an opportunity to collaborate with the patient in managing their risks and to explore the key interventions required to manage those risks. This, of course, is on an individualised basis. And we must remember that we don't want to be delivering observations in a way that could be considered punitive or custodial. That's why that two-way relationship is so important with each individual patient. Who is the policy relevant to? To state it simply, it's every inpatient. And remember, that also covers the 24-hour cycle of the hospital, so that's both day and night. There are 4 levels of observation: general, intermittent, eyesight, and arm's length. These are nationally agreed standard levels of observation, and they're contained within NICE documents. For the purpose of clarity with the policy, any observation beyond the frequency of general observations will be classified as an enhanced observation. So, general observations, every patient will be on these as a minimum. So this means the person should be observed every hour, and this covers the 24-hour period. Every ward has a hard copy of the forms to be completed, and the nurse in charge will allocate who will complete the observations, and that will be on a rota. Note that general observations is the only level of observation where a patient, is able to leave the hospital environment if they have agreed leave. Intermittent enhanced observation. This is a level of observation when a patient is assessed to be potentially, but not imminently, at risk of self-harm or potential risk to others. The care team will agree the maximum time period between observations, and this can be between 15 and 30 minutes. One really important thing to emphasise is that the policy states that the intermittent observations must be completed at irregular and unpredictable intervals. What that means in plain language is that if you see a person, say for example, at 2 minutes past 3, that's what you would record. And if they were on 15-minute observations, for example, you would then need to see them within that next 15-minute cycle, but you would always record the exact time that you had seen the person. What we wouldn't ever do is just do 0 minutes, 15 minutes past the hour, 30 minutes past the hour, 45 minutes past the hour, because that doesn't reflect reality. Because if you were seeing different patients, as I said, it may be at 2 minutes past 3, so that's what you would record. Please remember that patients on intermittent observations would not be leaving the hospital environment unless there was a plan in place to keep that person safe and they required urgent medical assistance. Within eyesight enhanced observation, so this level of observation is for patients assessed to be at the highest level of risk of harming themselves or others, but who can be safely supervised within eyesight. The patient must be kept within sight at all times, day and night, and this includes when the person is using lavatory or bathroom facilities. From a gender sensitivity perspective, we would always ideally have the same gender staff member that matches with the patient, wherever possible. And again, a person on eyesight enhanced observations would not leave the hospital unless there was a plan around medical assistance and appropriate plans were in place to keep them safe. Within arm's length, enhanced observation. So this level of observation is for patients to be assessed at the highest level of risk of harming themselves or others, and who need to be supervised at very close proximity. The patient must be maintained within, literally, arm's length of the observing nurse. On very rare occasions, this may require more than one nurse. The same applies with this enhanced observation, that the person would not leave the hospital environment unless there was a safety plan in place. Say, for example, they needed urgent medical assistance. I just want to emphasise some best practice with recording, and this includes learning from incidents nationally and within the organisation. I want to focus on the fact that when a patient appears to be asleep or resting, regardless of the time of day, you must continue to monitor their mental and physical health and noticing changes in body positioning and breathing. If you are unable to observe the patient move or breathe, you must ensure that the person is conscious, which may require entering the person's bedroom if they're in a bedroom area. When we also consider best practice and recording, the recording forms have changed to make them user-friendly for staff. So there are codes on the forms, and those codes are one-to-one, if the person is having one-to-one time with a member of the multidisciplinary team, a tick if the person is safe and present, an E if the person's out with an escort, U for out unescorted, A if the person's AWOL, SF is for asleep, breathing and lying face down, SB is asleep, breathing and lying on their back, SR sleep, breathing and lying on the right side, and SL is sleep, breathing and lying on the left side. These are recent changes made in March 2020 to ensure best possible practice with recording patient observations. Now, once you have completed your allocated time, you would hand over your observations to the next allocated member of staff and sign on the form to say that the observations have been completed. And general observation forms are retained on the ward as per our record keeping policies. Just a point about capacity and consent. All 4 levels of observation can be applied to patients detained under the Mental Health Act without their consent, although we would always try to seek that consent. Even if the patient declines, the procedure can still be applied to them. They of course retain the right to ask for a review of the observation to which they are subject. And continuing with capacity and consent, when we consider informal patients, if a patient objects to their observation, then the next step is to assess their capacity. If they have the capacity to object to observations, then pull together an MDT meeting to agree the next steps. A top tip in this instance, which is quite rare, is to use the information for patients, relatives and carers leaflet, Appendix 3, which is available on all of the wards, to help explain the reasons for observation. And that supports that collaborative approach with patients in regard to observations. Okay, so frequently asked questions. Firstly, what about the patient who has just been admitted? Well, all patients that are admitted are placed on eyesight observations. And this relates to learning that a person coming into hospital can be at an increased risk. However, we always want to consider the needs of the individual person, so we will look at their current mental health and physical assessment and their history and identified risks. Other factors we will pay attention to will be the patient's age and any individual physical or emotional vulnerabilities that increase the risk of trauma arising from specific forms of restrictive interventions. So we have that responsibility to protect patients, visitors and staff. We also will be considering medications and their side effects. A key point is this: the observation level can be changed by the admitting nurse and another qualified member of staff who is conversant with the knowledge and skills assessment related to the therapeutic engagement and observation policy. Continuing a little bit further on this theme, there's the question, what should we think about when assessing the safest level of observation? And apologies for this busy slide, but there are a lot of things to just consider. And I would always advise a team discussion to consider the appropriate level of observation for a person. But there are risks to keep in our mind. So that is a risk of the person potentially wanting to go AWOL from the hospital. The question mark around safeguarding, and is the person potentially likely to or is being bullied, and that also could include them being a perpetrator of behaviours which may cause us concern. We also want to think back to that new admission to the services, and we want to look at learning that has taken place from incidents that recognises that when patients are first admitted to hospital, there can be that increased risk. And that's based on a number of factors, but part of our considerations will be about, is this person unknown to services and presenting to us for the first time in an acute mental health crisis? So of course we're meeting as strangers really, and although we may have the risk assessment when they were admitted, we're still getting to know the person. So that will be a consideration when we're choosing that level, the safest level of observation. Also, if somebody's been transferred from a different ward or unit, that can be very disorientating for a person. So we'd consider then what level of observation will keep them safe. There's other things that can happen to our patients that can increase risks. So this is not the complete list, but things to bear in mind are if there's been an unsuccessful tribunal or manager's hearing or changes in a person's legal status. There could be issues about upcoming interviews with the police or attending court or other appointments that might cause distress for a person. Even a social visit. We mustn't ever assume that if a person's had a visit from a family member or friend, that that's always a positive thing. We need to be very receptive to the fact that there could be social stresses that are taking place. If a person's Section 17 leave has been removed for any reason, again, that may have an impact on risk and the level of observation that person may require. That particular issue can be hardwired right back to a person being an AWOL risk. We must also think broadly about physical health. And when we think of physical health, that could be a range of conditions that the person might have, which may increase their risks. And that could be everything from sensory loss, perhaps poor eyesight, right through to issues related to the risk of falls. If people are experiencing, or patients are experiencing command hallucinations, where they might have the intent of acting on those, that's an increased risk. Also, if we think about people who are under 18 years coming into an adult mental health facility, we would want that person on a high level of observation to maintain their safety. We mustn't forget patients with cognitive impairment. And also, when we're getting to know patients, we need to think of their psychosocial background. So that includes what's going on in their life in a broader sense. So that could be issues related to divorce, access to their own children, problems with accommodation or finances, and employment. And also we must consider the potential impulsivity of an individual patient, and perhaps on a depressive spectrum about their feelings maybe of hopelessness or agitation. Who can increase a patient's observations? In practice, any member of the team can recommend an increase, and best practice is to discuss as a ward team and record that decision onto care notes and to review the care plan. Don't forget to inform the patient as part of collaborative working with them. Who can reduce a patient's level of observation. This decision can be made by a qualified nurse and another qualified health professional who has completed the knowledge and skills assessment, Appendix 9 of the policy. And this decision must be recorded in care notes and the care plan of the patient must be reviewed. How do I complete general observations at night when all of the patients are asleep? How do I ensure that these observations are completed appropriately? And I just want to re-emphasise that the standards required here, the best practice standards, are when a patient appears to be asleep or resting, regardless of the time of day or night, you must continue to monitor their mental and physical health and looking for changes in their body positioning and breathing. If you are unable to observe the patient move or breathe, you must ensure that the person is conscious, which will require entering their bedroom. I'm undertaking intermittent enhanced observations at intervals of 15 minutes for a patient. When you go to find they're in the bathroom with the door shut, what do? It is essential that the patient is directly observed, so you would ask the patient to open the door so you could ensure they were safe. If the patient did not agree with that request, then you would escalate that matter and get support from the nursing team. But what is critical is that the patient has to be directly observed. How do I complete intermittent observations correctly? The patient's location and well-being must be checked at irregular and unpredictable intervals, ranging from 15 to 30 minutes. The maximum time between checks and the rationale for use must be documented on the intermittent recording form and in the person's records, care notes records, and the times must not be exceeded. Enter the exact time the intermittent enhanced observations have taken place using the 24-hour clock. You can also enter comments on the person's location, engagement if they're communicating with staff or other patients, any risks that are observed, the overall mental state of the person, and activity that they're engaged in during that observed period. Any further questions? I have put an area of top tips in that I just want to bring your attention to. Firstly, on the intranet, you can access policy on a page. And this is a very useful one-page summary of the policy. I would also bring your attention to Appendix 2 of the policy, and this is available in what we call a Z card, which is a fold-out card. And that will remind you of the different levels of observation and also best practice in respect to completing observations. And finally, Appendix 9 of the policy is the Therapeutic Engagement and Observation Knowledge and Skills Assessment, which is a series of questions which you can complete, because if you have listened to this presentation, you should feel informed to be able to answer those questions. And that confirms then that you have an up-to-date understanding of this policy. And my final comment would be, always ask somebody for help, or if you have any further questions, just bring them out in the open. Questions are good. So thank you very much.